Dr. David, welcome. Get in Anup also.
Thank you. Yes, thank you for inviting me to speak to you.
Dr. David, sorry for the delay. We are just 5 minutes overboard. So anyway, now please get Anup in. So welcome to India's second Metabolic Health Conference. So I'm Health Coach and a member of DLife.in, India's oldest, biggest, and the only award-winning platform, local platform. So me and Anup, we are the co-hosts, and we are bringing you this historic and scientific feast for India titled Metabolic Therapies. So today we have a special guest, Dr. David Cavan. Dr. David, welcome again.
Thank you.
So I'll give a brief introduction about Dr. David. So Dr. David is an international renowned physician specializing in the prevention, management, and reversal of type 2 diabetes and the intensive management of type 1 diabetes also. So for many years, he has encouraged his patients to modify their lifestyle rather than rely on medication alone to manage and reverse type 2 diabetes. His knowledge and experience in the field spans around 25 years as a consultant endocrinologist in the United Kingdom. Additionally, he gained international recognition as Director of Policy and Programs from 2013 to 2016 at the IDF, International Diabetes Federation. He currently works part-time at the University Hospital Dorset as well as at the London Diabetes Centre. He also oversees diabetes projects in a number of other countries, which has broadened his knowledge and expertise to support patients and healthcare professionals in managing diabetes. He has also contributed to the development of various education programs and authored constructive, easily accessible books for diabetes. So his latest book, How to Reverse Type 2 Diabetes and Pre-Diabetes, was published very recently in Jan 2024. First of all, Doctor, thank you very much for having my story in your book.
Thank you for contributing it and enabling us to share your experience. It was wonderful to have that.
So it was a thrill, and I think that was in 2019 or 2020.
That was in so the book that's just been published was previously published in 2022, first time round, and it's now been published in a compact format with a new title, just as you said, earlier this year.
Yeah. So please tell us, you were a mainstream doctor prescribing medication. What really got you into this lifestyle type, especially into low carb nutrition, that too being an endocrinologist? How was it?
Yeah. So as you say, I've been an endocrinologist specializing in diabetes for many, many years. And my focus for a lot of those years was that we need to treat type 2 diabetes with medication, because that's how I was trained. And the dietary advice seemed not to work. So although we knew we should be encouraging people to change their diet and lifestyle, it didn't seem to work. So we knew we had to rely on medications. And I guess I first began to question that about 15 years ago now, when there are a lot of new drugs coming out for type 2 diabetes, and a lot of them with a lot of hope and a lot of hype, promising that they would help people reduce their sugar levels and lose weight. And so sitting in my clinics in a hospital specialist care setting, I began to use these medications. I recommended them to patients, and I thought, this is great. We've got something new here. But what happened was the patients would then come back, and some would do really well and some wouldn't, nothing would change. But then a bit later, those that did well seemed to be back at square one. And so I really began to start asking questions. Well, why are these drugs not working? And it was about the same time that Professor Roy Taylor, also from here in the UK, had provided the first concrete evidence that type 2 diabetes can be reversed. And so I began to ask my patients questions. And for the first time ever, I started asking, well, what do you eat? And I feel ashamed to say that, because now most of my consultations, I talk about food. But until then, I never did. I thought, well, it's not relevant. That's for dietitians to do. My job is to write prescriptions for medications. But when I asked the questions, well, what do you eat? The answers came back. People were eating everything. They were eating foods with sugar in. They were eating lots of starchy foods. And at the time, the official advice was if you have diabetes, you should base all your meals on starchy carbohydrates. So they weren't necessarily doing the wrong thing, but it was then everything else in moderation. And what does moderation mean? Some people, moderation is a huge amount of sugar. To other people, it could be very different. So what I was learning was that people were eating foods that was pushing up their blood sugar levels. So it was no surprise. How on earth could their medications work in bringing the sugar level down if they're eating foods to push it up? So that got me really thinking. And I started to say to people, well, look, the traditional advice at this stage is, you come to see me, your sugar levels are too high. The traditional advice is I prescribe you another tablet or we increase your tablets. But how about, would you be willing to try changing what you eat? And I didn't have any resources or use anyone else. I just gave some very simple guidance. How about trying to cut out sugar? And how about using more protein in your meals and less carbohydrate? And that's all I did. And then people were coming back. And those that were able to do that, and we know a lot of people can't because we're learning now, I didn't know about it then, that addiction to certain foods and sugary foods in particular is a big problem. But people were coming back and they were saying, I was seeing that they were losing weight, their blood sugar levels were coming down. People who'd been on insulin for a long time were coming off insulin. And we used to think once you're on insulin for the rest of your life because this is a progressive condition. One of my early patients was someone visiting from West Africa. And before he went back home, he'd come off insulin. Now, for someone in that situation, insulin is very expensive. And it really got me thinking, why have we got ourselves into this situation where we're treating what is essentially a lifestyle condition with medications? And the rest, if you like, is history. So as you said, I started writing books. I've worked internationally, gained a huge amount of experience about what is driving people to develop diabetes, type 2 diabetes. And it is our modern day environments. It is our modern day foods. And we now know we can turn it around. So it's really now a great message of hope for the future, a healthier future, rather than more and more medications and less health.
Great to hear. Now, do you apply therapeutic carbohydrate restriction or low carbohydrate in your type 1 diabetes patients also?
Yes, I do. And I wouldn't use the word I apply it. I offer it as an option because at the end of the day, yeah, as a doctor or a health coach or a nutritionist advisor, we can say to people, we think you should do this, but unless they're really wanting to and they feel it's their benefit, they're not going to. So I never tell people to do anything, but what I do is provide options and give advice. And certainly for people with type 1 diabetes, especially now that increasingly people with type 1 diabetes are wearing continuous glucose monitors so they can see immediately they eat something what happens to their blood sugar level. And what they're seeing and what we're seeing is even though they're doing what we say, you give some insulin, then you eat, that their sugar level goes up often really high. And now people are beginning to see that. I say to them, well, okay, how about, well, first of all, what do you think about your level going that high? And often you're nearly always they don't like it. The answer is clear. It's not just to give more insulin because that could risk them going low. So I say, well, how about as an experiment, instead of having a bowl of cereal for breakfast, try some plain yogurt or some eggs and just see what happens and get them to learn by making those changes that their sugar level stays more stable, they need less insulin. And some people will then go on and apply that to all of their meals. Other people will just know that they've got something that's an option, that if they want to get their levels down by changing what they eat, they can achieve it.
That's great. Now, see, earlier, sometime back, the choice of medications were very, very less. We had metformin, we had sulfonylurea, some maybe secretagogues and glitazones, and then let us say insulin. But now we have a lot of other options coming in. We have insulin analog, GLP-1A, SGLT2 inhibitors, DPP-4. So even with this, do you think the control is still difficult with so many medication, especially the newer ones doesn't cause hypo?
Well, exactly, and it was at that time when the first GLP-1 analogs were coming out and the DPP-4 inhibitors were coming out. That's when I got really excited about prescribing these new drugs, and I then became very disenchanted, because what my experience showed, and what I think is ubiquitous, is that these drugs can be very, very helpful, but they haven't got a chance in someone who is constantly feeding themselves foods that push up their blood sugars. And that's really why and I still prescribe these medications, but I would always say to people, look, these can be really helpful in controlling your diabetes, but you have to see them as they are there to help the diet that you're following. You know, you cannot see them in place of a diet. And what I find so unfortunate is that many guidelines now, people interpret them as saying that almost at the diagnosis of type 2 diabetes, you have to prescribe metformin and you have to get people on medications, and it medicalizes it. It makes it a medical condition. Whereas we know at that point, if people are able and willing to change their diet, we know a huge majority can achieve remission. And so I would always encourage colleagues to emphasize the importance of lifestyle change first of all. Yes, they might need medication, but the lifestyle is what's going to is going to be the main intervention. The medication can help it, and sometimes only for a short period, and it may then be able to be withdrawn.
I think that's why, even though there is a plethora of medications available, we do see people with diabetes coming in with a big prescription in India. Still, the HbA1c is very high. It is 8 or 9 or sometimes 10. And practically every medication which is available in India will be there. And all these are available, including the newer drug like imeglimin is also available in India. Still, control is not achieved. And as you said, the root cause or the very basic or foundation of a diet is not addressed. And Indian diet, is full of starchy carbohydrates. 70-80% of our plate is grains. It's also a grain-based country. And that is why probably the control is missing in spite of so many. What about this advice of diabetics can have everything in moderation? One, and this multiple meal, having meal every 2 hours.
Yeah. So everything in moderation, as I said earlier, it means different things to different people. So I have some weaknesses. I really like ice cream. Okay. And so if I enjoy ice cream, I like a large amount of ice cream. I don't do it very often because it's clearly not good for me. But so what to me might be a very small portion of ice cream could be a large portion to someone else. What does moderation mean? It's completely meaningless. And I think the second point is everything in moderation would be fine if we could quantify what moderation means. But if you have diabetes, any type of diabetes, by definition, your body cannot handle carbohydrates, sugars or starches. So a moderate amount of sugar is going to have a much worse effect on someone with diabetes than a moderate amount of protein or a moderate amount of fat. It's like saying to someone with a peanut allergy, just have a moderate amount of peanuts. It's a complete nonsense. So where my practices change is to say to people very specifically, look, I encourage you to work out using your glucose monitoring or a sensor. Find out what are the meals that push your sugar levels up, and then look to change those to meals that don't push them up. So it can become personal to each individual as to their meal choices that they can adapt themselves. But giving some guidelines that basically sugar and starches are going to push your levels up. And to be honest, I say to people, as long as you can manage your sugars and starches so your glucose levels stay within range, I don't really mind what else you eat, because for your health, for your future, they're the things that are really going to make a difference. You know, we're not talking about any other type of condition. We're talking about diabetes here. The other point you mentioned is this idea that if you have diabetes, you have to constantly eat through the day. I mean, this again is something that is still recommended by some practitioners, and yeah, I'm literally speechless, okay, in trying to justify it. But let me take you back to where that came from. If we go back to when I very first started practicing, which is over 30 years ago now, people didn't have all the technology that they have now in terms of insulin and glucose monitoring and what have you. And if you had type 1 diabetes, you had an injection of insulin once a day, maybe twice a day, and you had no way of monitoring your glucose levels. And so in order to stay safe, in order to avoid the risk of hypoglycemia, because the insulins in those days by today's standards were relatively primitive, the absorption was very erratic, people were advised to eat frequently, eat carbohydrates frequently through the day as a safety mechanism. That somehow became the dietary advice for everyone with diabetes. So that was bad enough, you know, even people who aren't on medication for diabetes. But what's even worse is that now, you know, 30, 40 years later, when we have all the technology that we have all the monitoring capabilities that we have, and I accept that in many countries these cost money and they're not readily accessible, but you know, they are there, and yet we still promote a eating pattern from 40 years ago. It is nonsense. So yes, that is very often seen still in guidelines. And what I say to people is, look, eat when you're hungry. Don't eat if you're not hungry. And you know, one of the other things that I've learned in this journey in the last 10 years is the benefits of fasting and intermittent fasting. And if you're not hungry in the morning, skip breakfast and you get a prolonged overnight fast, which is really good for you. And so many people say, I never used to eat breakfast, but when I developed diabetes, I was told I must eat breakfast. And it's great, really liberating. No, you don't have to eat breakfast.
Approximately how many patients have you treated with low carbohydrate diet?
That's a really difficult question to answer, because my clinical practice for some years has been quite small. So, but just about everyone who encounters me, we will have a discussion about, and I will offer them it as an option, and a lot of them do pick it up. But I also, you know, have more indirect influence by helping set up projects in different parts of the world. So, you know, I'm not a full-time clinician where I've got big numbers of patients and can report on, but you know, it must be in the thousands, because I've been doing it so long.
That's significant number. So do all the patients achieve remission, or is it a spectrum of remission and lower medication?
That's a really good question.
Difficult is remission? How difficult is remission?
It's a really good question, and it depends on so many things. Now, we know that the closer you are to diagnosis, the evidence would say the greater your chance of achieving remission. And when you've had diabetes for many years, that ability to achieve remission is reduced, and there's a lot of work to show changes in the pancreas and what have you can become less reversible over time. But it is never too late, and I have had patients with diabetes for over 30 years and been on insulin who have been able to achieve remission. So everyone is different. But the way I describe it to people is that we know that this diabetes disease process, as I call it, we know that that can be reversed. We know that there are certain changes you can make that can help reverse that process, essentially carbohydrate restriction in different ways is, there's a lot of evidence for that now. And so I encourage people, if they want to go down that route, to make changes to their diet with support if needed, to reduce their carbohydrates, to reduce their glucose levels. And some of them will achieve remission. They'll come off their medication, they'll lose weight, and their diabetes will be in remission. Some will maybe achieve all of those things, but their HbA1c, which could have been really, really high, may have come down to 6.8%. So they're not in remission, but their future health outlook is still so much better than an HbA1c of 12% and being 20 kilos heavier and being on lots of medication. So I think we've got to be careful not to say, well, it's either remission or you've got to achieve remission, and if you've not achieved remission, you've failed, because that is very demoralizing and it's not true. Any success in helping people lose weight, reduce their glucose levels, come off medications, they're all successes and all lead to better health outcomes for the future.
So I think from your point, I'll gather that there's a spectrum of 3 factors. One is complete remission. One is lowering of medication with better control. And third is medication may not lower, but you will get a better control, as you told. With the same medication, they were at 12 and now they are at 6.8 or 7. That itself is a win.
Yes, absolutely. And, what I have, you mentioned that 10 years ago, I worked for the International Diabetes Federation, and I had a lot of conversations with pharmaceutical companies at the time. And of course, in a sense, they're not really interested in remission because their model depends on this being a chronic disease that requires more and more medication. And I tried to encourage them and to do some studies to show how their drugs can help people achieve remission, because it will make their drugs look so much more effective. And the HbA1c drops will be so much bigger if they promoted lifestyle change and carbohydrate restriction alongside their medications. But you can guess the answer. No one was interested.
I can guess because I was a pharma rep for 35 years. So I know I was in diabetes. I was in diabetes and cardiovascular segment. So I know all this. So now in the spectrum of low carb to ketogenic diet to carnivore, what is it that you favor in your patients? So we have low carbohydrate, maybe 100, 120 grams,
Yep.
ketogenic diet 30 to 50, and then carnivorous approach. So what is it you favor?
I favor whatever is most sustainable for that individual patient. And I have been criticized very vocally in a public meeting by not advocating a ketogenic diet for all of my patients. And we've got to be very careful, because people who follow a ketogenic diet, by definition, find it relatively easy to do, and they tell everyone it's so easy, and look, I've achieved this huge amount of weight loss and I've put my diabetes into remission. I think we need to be a little bit humble and accept that humanity is a huge range of people and preferences and abilities to change. So I have absolutely no problem. I will support patients who follow a ketogenic diet, including in type 1 diabetes, because I think it is extremely effective and will help people achieve remission. But equally, I have patients who follow a more moderate low carbohydrate diet of 70, 80 grams a day, still achieve remission, but their preference is to enjoy some starchy foods with some of their meals. And I perfectly get that, and I can understand that. And so it's not And yes, there's a big move now. We're hearing a lot about a carnivore diet. I don't have any particular um, strong feelings one way or another. But if people do well on a carnivore diet, that's fantastic. I have no problem with it. The key thing is we need to get away from this diet, this notion of a diet as something that you do for a while. It needs to be a lifestyle. It needs to be a long-term change in eating habits that suits you and is going to be sustainable. Otherwise, it doesn't work. And just one point about the ketogenic diet. So Virta Health, that you'll be familiar with in the US, that has done some amazing work at promoting and recommending a ketogenic diet to their patients. They're seeing really good remission rates and sustained. On the face of it, really good evidence for the long-term efficacy of a ketogenic diet. But when you drill down and actually look at what they report, because their patients monitored their ketone levels on average were very low. So they were still achieving up to 60% remission, despite not being in ketosis. So I think I think we need to accept that yes, a ketogenic could be approach could be very beneficial for people, but it doesn't have to be necessarily. Dr. David Unwin has a GP in the UK. I think he's surveyed his patients and found that the average carbohydrate intake of patients in remission was about 77 grams a day. So that's not ketogenic, but it's low carb, and they've achieved remission.
See, I think that's interesting. Like I am a lacto-ovo vegetarian and I am on a ketogenic diet for almost 8.5 years and at a very low ketosis level, 0.5 millimoles per liter. And maybe sometimes I do break away also. So I perfectly understand. I do, as a health coach, I do see a lot of clients. I work with diabetes primarily. And I realize that application of ketogenic diet in Indian context is not easy. So the spectrum of 100 grams to keto is whatever is possible. And Anup Singh of D-Life, he's the one who has little Indianized this whole concept. Earlier in India, we used to think it is ketogenic diet, 30 grams. But Anup Singh had developed that 100 grams where he has made it possible for us to include some grains, a little bit of grains and all, so that it's very easy for people. And I think your approach is quite practical so that people will continue. If I am in a ketogenic range for long, my HbA1c will be 4.7 to 4.9. If I break away slightly, it will be reaching a maximum of 5.2.
Yeah.
I have never crossed 5.3 in this last 8.5 years.
Fantastic. So you've done really well, and it just goes to show that you can stay in remission. I was just going to reflect that I've done some work with a colleague in Kenya who's set up remission programs, Dr. Daniel Katambo. And there he says there's no way that he can tell his patients not to eat the traditional starchy food, the ugali, that is part of their culture and has been for centuries. And so we've got to be culturally sensitive as well. But by highlighting to his patients that the huge amount that they have got used to eating is having such a big effect, and if you could just halve it and replace the rest with vegetables, you can see a big improvement. And he's seeing his patients achieve remission while still eating some of this starchy food. So we need to accept the realities out there. We need to accept the cultural context in which we are, and also accept that people can achieve remission while eating some starches.
Yeah, I think the combination of a bit more starch, exercise, adequate sleep, I think this really works very well. Intermittent fasting, of course. So exercise, intermittent fasting, a bit more starchy carbs works for most people.
Yeah, I mean, great, and it's really great that you've introduced those other things, because it's not just what we eat that pushes up our blood sugar levels. I mean, the next biggest thing in someone with diabetes is usually stress, which can be exacerbated by poor sleep, which can be exacerbated by illness and everything else. So absolutely addressing those other things is probably going to be more important than driving down eating even less. You know, if you get so stressed out because you can't eat any carbohydrates, then your cortisol will push up your sugar level and disturb your sleep, and you'll end up back at square one.
Now, very important question. Did you experience a lot of pushback from the others, from NHS? How is it? How did you manage to?
Yeah, it's so I was, you know, I was quite fortunate. I made this change in my practice when I was relatively senior, so it was more difficult for people to push back against me. But even in the last 5 years, I have experienced it, particularly from, you know, some other people working in diabetes who just saw that this was a fat diet and I shouldn't be putting my views on patients. And it's yeah, it has been quite tricky, but again, because I'm relatively senior, I've been able to say, well, okay, that's your point of view, but this is what I offer my patients. What's very interesting is that pushback has diminished significantly. And what happens is that the patients are coming back into the clinic where I work, and they're losing weight and they're coming off medications and they're feeling better. And so, you know, people are seeing that it actually is beneficial. So the pushback is a lot less. And I think the other thing is that there is such a big move into this area from a lot of people, you know, in primary care, health coaches, nutritionists who are all seeing benefit, that actually the pushback, you know, people can't push back anymore because it's seen that it is an approach that works really well.
I think it has already come into ADMNT somewhere in 2019 or the earlier 2018 consensus report with ESD, Diabetes Canada, and recently Diabetes Australia has also tied up with defeat diabetes, and they have included low carb as in one of the best practices. I think these are some of the advancement. So do you see something like this happening in UK?
Oh, that's a really good question, and you're absolutely right that the ADA has endorsed it as an effective approach for a number of years. The Australia story is fantastic, because I was talking to colleagues in Australia just a few years ago where they were saying that there was a actual denial amongst the establishment that remission is possible. So that has been a great turnaround. What's so sad, though, is although the ADA has the position that it has, it's still, you know, a lot of its output is still talking about type 2 diabetes as being chronic and progressive. They put on their website recommended meal plans which are full of sugar and starch, and you just wonder what on earth is going on. In the UK, there is, I guess, a grudging acceptance because there is so much evidence, people can't ignore it anymore. But we have not had this wholesome embrace of carbohydrate restriction as you've seen, for example, in Australia. And you know, it is still a work in progress.
But that's the BDA, British Dietetic Association. They do have something on low carb, if I'm not mistaken.
Oh,
Something.
absolutely. So the British Dietetic Association and Diabetes UK and others, they put together a consensus report a few years ago, which was very supportive of it. Diabetes UK, on its website, it talks about low carbohydrate meal plans. But elsewhere on its website, it says base your meals on carbohydrates. You need carbohydrates for energy. So it is a complete mishmash, and there isn't a coherence. It is very much left as it is an option, but you know, it is difficult. So, you know.
Yeah. So I think we have 6 minutes left. Please tell us about your other work. You are doing some training programs on low carb. What exactly is it? Is it for coaches, for nurses, or for doctors? What is it?
It's for any. So you're absolutely right. For many years, I've had a great interest in training professionals in different aspects of diabetes management, and for the past 5 years now, I've been running a short course, and it's open to anyone involved in the management of people with diabetes. So we've just finished a course this week, actually, and we had consultants, consultant endocrinologists on the course, and we had trainee health coaches on the course. So we have the whole spectrum, and I make it open. And what I say to people is, yeah, it's very multidisciplinary, but actually, you know, if you're a consultant endocrinologist, you've never been taught this before, so you need to start from scratch, just as someone who's just coming into the field of diabetes. So it's open to anyone, and we just introduce the basics. We introduce the physiology, the evidence base. We have case studies, very much as I put in the book, and we have patients who've put their diabetes into remission talking. And we have people join from all around the world because it's online. So we have someone from Canada and New Zealand, and we've had people from India before, but I know you're providing all of that there anyway now. So yes, and it's something that we do because I want to make this as accessible to as many people anywhere so that they can offer it to their patients. The other thing that I've been doing, as you mentioned, is writing books over a number of years. So that's another way I want to get this message out. And then I support projects in different places. We set up a project in Bermuda, which a very small island, very wealthy, but huge problems with diabetes, very, very bad US influenced diet. But again, if you can get people making the right changes within that context, they too can achieve remission of diabetes.
So after this training, how is the response of the doctors? Do they go out and practice low carb in their patients, or are they still reluctant, or they do it in a small scale? How is it?
That's a really good question. I mean, what I do is I actually get people, and it's only a short training, it's an introduction, but I get them before we finish, while we're still online, to write down, okay, what are you going to do to change your practice as a result of this? Because I've been on courses, I've got really inspired, and you get back into the routine and nothing changes. And so actually getting people to focus, how is this going to change your practice? And obviously we've got people at all different levels. But, you know, if I've got a trainee health coach on, you know, who's getting the training, then they can identify within what I do, without needing anyone else, how can I change what I do? And it will be how they interact with a patient. A consultant might say, well, okay, I'm going to set up a service, but I don't have that information. But the feedback I get is people find it very helpful. It's just to get them thinking about it, get them started, give them some tools. And yeah, perhaps I should write to them all now after 5 years and see what they've done.
I think it's really great. I think we have covered a good deal of discussion, and I think this is whatever we have discussed is really pertaining to India. The situation, I think, more or less similar. You do see Indian patients there also, but I think whatever we discuss, I'm sure this will go a large way in the Indian public making an informed decision that whether they want to go for a low carb, or they want to apply low carb along with medication, or just follow the medication part, whatever it is. So I think all in all, it's a great discussion. I'll request Anup to come in. Anup, you're there? Arti, get Anup in.
Yes, sir. Anup, sir, please turn on your webcam.
Fine. Anyway, I think he must have gone out somewhere. So anyway, I will take this opportunity to thank you, Dr. David.
Can I just add, sorry, just to very quickly, I was going to come back to you about the situation in India, and it's the same in many countries around the world, is that, you know, we're lucky in the UK, people with diabetes, if they're on medications, they don't need to pay anything for them. If the focus is on medications, in many countries, it's a non-starter because people can't afford the medications. So I feel this message is so much more important in those sort of places where we have a real ability to turn this tide around by helping people help themselves and saving money.
That's a very great important point you told. Yeah, we do spend everything from our pocket. So whether the drug is cheap or costly, it just pinches our pocket and we have to pay it from our salary. I think it's a very important message you have given that Indians need to adopt low carbohydrate diet in whatever small way possible. It may be just lowering from their 300 grams. Even if they lower it by 100 grams or 150 grams, they will still gain a better control and possibly lowering the medication. And I think it's a very important point to touch. Dr. David, thank you very much. So diabetes is a topic where I can talk for 8 hours and you can also talk for 8 hours. It's a topic which is dear to my heart because I myself am in remission and I've been selling anti-diabetics for quite long in the pharma industry. So I'm very, very familiar and very happy to discuss this. So we'll have you again, once again, in some future sessions. So
Well,
I want to thank you again. Thank you, Dr. David.
thank you so much for inviting me. It's been a great pleasure to talk to you.
Thank you. Namaste. Thank you very much.
Bye.